Right then, good morning. We're live. 10 o'clock, a slightly later time today. Normally we're 9:30, but for this week's guest, I was prepared to move the sun, the moon, and the whole of the constellation. It's none other than Mr. Ben Cormack, who I will be bringing up with us shortly, because today's episode is all about pain and understanding pain and how understanding pain can help runners on levels which you wouldn't even imagine. Okay, the whole aim of it is to keep it simple, interesting, and engaging for the runner. There's plenty of information out there for therapists, but I do feel there's a bit of a lack for runners, which is what this whole show is about. Before I bring Ben Cormack on, just to remind you that this show is now available as a podcast. It's all over iTunes. It's on Podbean, Stitcher, Spotify, you name it, is up there. So just do a search for RunChatLive or check out the comments. I'll put some links later on, and do please like and share. So yeah, without further ado, I think what I'll do is I'll bring on Mr. Cormack. An exciting countdown of 3, 2, 1.
Hello, Matt.
Hello. Let's let everybody see your lovely face, shall we?
And it is a lovely face, Matt.
There we go. What else could I do first thing Sunday morning? How are you, mate?
Yeah, not too bad. I mean, you know, it's a Sunday.
Oh, no, I really do appreciate
it.
Yeah, and of course, normally you're kind of dipping your toes in the beach at San Diego and kind of living jet style, rich and famous, aren't you? Or
well, I think more I tend to be working on Sundays teaching. So actually, it's nice to not be working for once.
All right. And you got a little one as well, haven't you? Rafferty?
My little man is 7. Yeah, so that's a full-time job in itself.
Oh, that's amazing. I love I love following you for all sorts of reasons. I don't mean literally, I mean on social media.
I wondered who the bearded fellow was. Whenever time I turn around,
I'm there, this big shadow. No, because I mean I left kids quite late, and so it's nice seeing fathers out there with 7-year-olds. Mine's only 3.5 and 1.5, so I get tips of what to do, and in your case, what not to do. So it's useful. It's great. It's really useful.
Right, Matt, I'm off. If you're going to insult me like this.
Anyway, so no, thanks again. Really, I really appreciate it, and hopefully anyone watching this and watching the recording later on will do as well. So yeah, I've set you quite a hard task for today, because obviously any therapist will know, and you above anybody, that explaining pain is not that simple. Because we don't know that much about it ourselves, and getting it across to a runner, for example, without filling their heads with even more of a mess is pretty difficult. But that said, I thought the way we could start off, and the way I tend in clinic maybe to approach the subject, is just kind of give some examples of how pain can be weird, and how that opens the door to maybe help runners think, actually, no, it's true now you say that. Oh yeah, that is true. And that opens the door to maybe some explanations and some kind of getting rid of some of the preconceptions we've got about pain. So yeah, so Mr. Ben Cormack, how is pain weird?
I mean, a bit of a weird question to start in itself. So I think what I might like to say, I think, is what is a fundamental key message that people need to know about pain, right? And so if we were going to look at pain and think about pain, I would say, in a sense, I suppose it shows the weirdness of pain in a way, but certainly I think fundamentally that pain is, that it doesn't always mean that there's damage or it means that there's harm. So we can have pain, I think fundamentally most people understand pain as being reflective of an injury or reflective of some kind of damage to the body. And I think the more we understand about pain, the more we realise that lots of things can influence pain, and pain also isn't always reflective of actually what's physically going on within our bodies. And I think that, that shows the kind of the weirdness of how much we don't actually understand always about pain. It's not just about kind of damage or what have you. So what are some other situations we might get where pain is weird? Certainly pain does things like move about, and it jumps about, and it goes from one place to another place, and pain feels different at different times, and the intensity of a pain will feel different at different times. And one day you might go for a run and you might get pain, and another day you might not get as much pain. pain doesn't seem to be kind of constant, and it's not always really associated just specifically with what we might see as damage or something like that. So I don't really know if that answered your question, Matt.
No, totally. Yeah, that's brilliant. And all of those situations you've just given help runners realise, oh, actually, just because my knee hurts, it's true. Some days it'll hurt more, some days it hurts less. The way it can suddenly set in at exactly kind of 10 miles to the kind of meter sometimes, it can be that accurate. The way...
Why didn't it hurt when I started running?
Exactly. Yeah. So I think this does definitely open the doors. I mean, I think where a lot of therapists start opening their mind to pain is the whole subject of phantom limb pain, which runners might not be aware of. But yeah, do you ever use that or talk about that? Is that a good demo of how pain is weird?
Well, I suppose that, if we attribute pain to a problem with the body, and suddenly you get pain in a body part that doesn't actually exist, well, that shows that it's a pretty weird scenario, doesn't it? So actually 80% of amputees suffer from phantom limb pain. So it's not like it's not actually a strange phenomenon. It's a very normal phenomenon, although it's strange in the way that it works. So absolutely. So if we think that pain is about damage, and I haven't got a body part to be damaged, but I've still got pain in the body part that I haven't got that isn't damaged, well, that's goddamn weird, isn't it?
It is, yeah. And I think it's a great thing to start off any conversation with. Pain is weird. It makes patients or clients or runners understand, it's not simple.
Let's say a classic pain example for a runner is patellofemoral pain. That's what's it called? What's the colloquial term? Runner's knee. Right, so we would have patellar tendinopathy would be jumper's knee. Patellofemoral pain tends to be runner's knee. Now, one of the weird things about patellofemoral pain is it's very, very hard to actually locate where it is. So it will be around the joint, and it will be up here, and it will be down there, and I'll palpate the patient's joint, and it will be like all over the place. It will hurt one place, or it won't hurt another place. It won't hurt on palpation, but it will hurt on this. And it just behaves it just behaves in a way that isn't congruent with how we might understand pain from a rip or a tear or a cut or one of those kind of more not normal pain situations, but maybe how we might view pain traditionally. So probably location is one of the best ways that I think people can start to get their head round the fact that pain doesn't always work specifically in the way they may feel it works, whether that's it moving around or it's going from the top of the leg to the bottom of the leg, or, when it kicks in and all those type of things. So I think sometimes when you work with people and you talk to people about pain, one of the best ways to help them conceptualize pain is actually to talk to them about their pain. Actually say, this is your pain pattern or your pain situation. That's not, that doesn't fit in with maybe how you perceive pain to be. So I think the best way for people to do it is often conceptualize it within their own story. And they may say, oh God, actually, now you come to mention it, it does move about a bit, or the intensity does change, or it does, happen at this point or not at this point, or when I didn't expect it or when I did expect it. And that in itself, in the person's story, often helps them understand about pain a little bit better.
Yeah, no, brilliant. I mean, I think because traditionally, some runners now are aware, they've read articles and things like fibromyalgia and chronic pain and persistent pain. But I think I noticed a post from you the other week, which kind of explained that we shouldn't really think that the brain and nervous system's only involved with chronic pain and kind of pain disorders. It's still a factor in acute pain. So if a runner comes to you and they've just come in the door and gone, look, my Achilles is hurting, I did it a week ago and now I did it. Is there still something to explain about pain there in terms of rehabbing it or recovering from it?
Well, I think it's everyone. One of the big things that people have with Achilles tendinopathy, one of the big things that people come in and they're worried about is rupture. So it hurts. Is it going to rupture? So I think understanding pain and understanding tendinopathy a little bit better, and the fact that, it may be, there's lots of good tendon in there, and that, even though it's painful, it doesn't always mean it's damaged, and it can still look really bad on a scan, and it may not be painful, or it can look really good and it's still painful. What I think that helps to drive a wedge between is the idea that it's suddenly going to degenerate or deteriorate, and also that it's going to rupture. So understanding that pain is separate from structure is important in all pain scenarios, because one of the big things that people worry about is kind of making the problem worse. And often that's linked into the state of the tendon. If it's the back, it might be the state of the disc. If it's the meniscus, it might be the meniscus. If it's, you know, whatever pain situation, if we see it as solely linked into structure, more pain tends to equal more damage, which tends to scare people and worry people. You know, so I think it's fundamental that even in acute, remember, acute only is a time frame. So acute and chronic are time frames. So beyond that, why, you know, that then they don't tell us much about why you have pain, unless someone you know, dropped a brick on their foot and they've smashed their toe to pieces. Then I can tell you that's probably because you've dropped a brick on your foot. You know, and you can look at your foot and there's a brick dropped on it. But in most scenarios, especially running injuries, which tend to be quite unclear in terms of source, you know, not many runners will tell you, you know, I suppose the biggest running injury I might see that there's a mechanism behind, a really specific mechanism, would be someone who's like stepped on a dodgy paving slab and twisted their ankle. And then we can say that's exactly that. Most running injuries are what we might describe as insidious or kind of sneak up on you. And I think in any of those situations, it helps to understand what pain means, what pain is, and how you kind of put that into your rehabilitation program.
Cool. Yeah. So you picked up on the fact that we can help runners by explaining that, or what it isn't, to a certain extent. If they're worried that they've torn or done this, or they've read something, then that can help reduce pain. And we've talked about that in other episodes of RunChatLive, the importance of communication and metaphors and fear and that. Then there's the other angle as well, where runners maybe think they can just fight the pain, just keep running through it. So that's where education can help as well, can't it? The other side of the equation.
Yes. So I think there's two ends of the spectrum of pain. So one end would be the kind of pain motivates me not to do things. So avoid, you know. And then the other side of pain would be pain is weakness leaving the body, or no pain, no gain. And equally, I think they're two problematic ends of pain. You know, there's this healthy middle zone where I think that if you experience pain, it's probably telling you something. You know, if it's pain during running, it's telling you something that maybe you need to think about, maybe the amount of miles that you're doing, or maybe your sleep, or maybe your nutrition or something. You know, I think there's always a message in it to some degree. But, you know, at the end of the day, we should have a healthy perception of the message. So seeing pain as weakness leaving the body and no pain, no gain is not having a healthy respect for pain. You know, to be honest, it's stupid.
Yeah.
You know, it's stupid. You know, you've got pain. And if it's running related, then it's probably something to do with running, and keeping going, running is probably not going to help it. Pain is not going to go away by running more. I can almost guarantee you that. Whereas some other people, it may be actually that they get a little bit of pain and they shy away from running. So that you know, now they decondition. Now they, you know, now they may become more sensitive to pain, because, you know, it's like hypertrophy. The more I work my muscles, the bigger I get, but the less I do, the smaller I get, right? So at the same point, our sensitivity and tolerance to pain is probably like that as well. You know, so we have to think about it from both ends of the spectrum. So understanding pain, I hope, gives us a healthy perception of what pain is and how we should respond to it. Either end of the spectrum are unhelpful. No pain, no gain. That's a load of bollocks. And at the other end of the spectrum, sorry, I'm an honest Cockney fella.
Excellent. So on iTunes, you now find this podcast in the restricted age category. Thank you, Ben. Continue.
Yeah, it's a Sunday morning. I'm usually at church, to be honest. So I'm
thank you for backing it up. Mention the Lord, and we're back down to PG. That's good.
Yes, he's on my side. Don't worry. There'll be a divine intervention somehow. And also the other end of the spectrum, where we're too afraid of pain, is also problematic as well. So let's be in that middle ground. A little bit of pain is normal and healthy. You're going to get it. If you're a runner, a footballer, a tennis player, whatever sport you do, pain is going to happen, right? You're going to have to deal with it. Don't try and run through it always. Don't give it too much respect. Understand it happens. It's normal. Let's stay in that middle ground, not be afraid of it, but also not afraid of it.
Yeah, definitely. No, good message. Definitely. I think the big problem is, especially with runners, there's a conflict, or they get confused between pain and effort, don't they? They think, tight or even fatigue to a certain extent. I think they're confused. Look, you can get through this, pull yourself together, be positive. It's just kind of your body's getting a bit negative, but they're totally different. Well, they are connected, but runners shouldn't confuse pain with effort.
Yeah, body sensations are funny, aren't they? But we know that triathletes, for example, who have better natural pain killing systems than your average person off the street. Let's be honest, if you run a marathon, you're going to have to go through some pain, right? That's undoubtable. But I suppose it's how much we overcome our body's natural, responses. So one of the issues, I suppose, is that we've become too cerebral, haven't we? We've become too executive function that, we can choose to avoid, or we can choose to go through it. And sometimes we need to, sometimes we can have too much or too little kind of perception of what's occurring. I'm not sure perception's the right word, but it is a Sunday morning.
Yeah, I won't lead you down discussing different
Let's not complicate it, mate. I've still got to go to church, so.
Let's give you a bit of an easier question then. So, let's bring this up here. You're going to like this one because I think you'll be able to answer this in a few words. Let's bring it up here. There you go, mate. Take it away.
What causes pain? Oh, blimey.
I love the way you were taking your jacket off.
Jacket off and all sorts going on here. What causes pain?
Remember, you're talking to a runner who now understands about the weirdness of pain and that it can spread and it changes. You've already hinted that kind of the brain and nervous system are involved, but any nutshells or metaphors or gems you use to kind of explain?
I'm going to be really honest with you, Matt. Honesty I find is the best policy, unless it's with your wife, of course, when honesty isn't the best policy. But I didn't say that. If you're watching, darling, I didn't say that.
It's recorded.
I know. I'm going to get it now, Matt, aren't I? Look, so I personally mostly try and steer away from the idea of causation. I'm going to be really, really honest with patients I work with, because I think we don't know. We don't always know. So running, let's be honest, right? Running injuries. What probably causes most running injuries, Matt?
According to the statistics, the data, kind of overtraining, inappropriate loading. Yeah.
Running.
Yeah.
So if a runner comes to me and they say, "Why have I got this running-related injury?" and I'm going to scratch my head and I'm going to muse. I'm going to say, "Well, it's probably running." So, that would be most likely what the data suggests. Running-related injuries are caused mainly by running, training error, although there was a new paper that came out recently, like 2 or 3 days ago, that actually said volume of running wasn't that well related to running injuries. So that's another So I don't like to be disingenuous. I don't like to, say it's because of this and it's because of that. So we know that pain is complex. It could be chemical, it could be mechanical, it could be, the joint, the ligament, the tendon, the this, the that, or the other. If I can try and find that clinically, I'm going to try and do it. I'm often much better at giving you a location of your pain and it's painful rather than actually telling you the exact reason why. But I think it's healthy to look at the idea that maybe how we manipulate our running is going to be the most likely solution to having a positive effect. But also, could it be rest? Could it be nutrition? Could it be all these other factors? So one thing I do know about pain is not just a singular cause.
All right.
So we know that sleep has an effect on pain. We know that stress has an effect on pain. We know that overtraining has an effect on pain. All these factors. So there's so many different things that are going into this thing that we call pain. We call pain. That for me to pull one out and say it's this, again, it's just not likely to be honest. But I'm going to say there's a whole bundle of things that we could have an effect on that might positively influence your pain.
Yeah. And I think you just answered the question wonderfully.
Oh,
you just answered the question. Yeah, you just said loads of things. Loads of things cause pain. Because that's what runners don't get.
Yes, the multifactorial nature. So a great example I use is football injuries. What causes football injuries to go up at Christmas?
I'm going to take a guess here and say football.
Oh, genius, man. Football, they play more games. Guess what happens? Injuries tend to go up as well. When do injuries tend to occur during sports? When we get times of fatigue and when we get, you know, all these other factors that come into it. So what's the really cool thing about all this, though? These are factors we can manipulate. And that's the best thing. Don't worry about the exact cause. You know, is it a rip? Is it a tear? Well, most likely no. What I know about the biology of pain tells us pain is mostly chemical. And that could be some really, really fancy things that I'm not going to go into that would blow our mind neurobiologically and all this kind of, you know, stuff that we probably don't need to talk about. Let's talk about the positive stuff. We can't always pinpoint the cause. There's a whole bundle of reasons that it could be, but there are lots of things we could positively manipulate to help you.
Yeah. No, definitely. That's a massive, and then that in itself is a huge message for runners. That's what I was hoping to get out of you, and the fact that because most runners will think my knee hurts because I've got something structurally wrong with my knee.
So what did I say at the very beginning, Matt? What's the key message? Hurt doesn't always equal harm.
Exactly, yeah.
And that's what it fundamentally boils down to. So what we know about patellofemoral pain is that patellofemoral pain jumps about, it moves about, it's hard to locate. You know, it's actually a diagnosis of exclusion, patellofemoral pain. What you actually do is you rule everything else out and say, guess what? It's pain in your knee. And they nod at you. People nod, yes, it's definitely pain in your knee. So one of the things is that patellofemoral pain is unlikely to be structural because you've gone through all the structural tests, which is fantastic. I can tell you it isn't. And I can tell you that it probably isn't just your structure. You know, I can test your fat pad. I can test your ligament. I can test your tendon. I can test all these other things. You can mostly function really well. It just hurts when you run. That probably tells me structurally it's not too bad. I also know that the structures of runners, their knees are no worse than the structures of runners or people who do not run. So we know that running doesn't detrimentally affect structure. But we know that running sometimes can cause pain because you might be doing, you know, potentially a little bit too much.
Yeah. No, brilliant. Okay, then. So knocking on from that, a direct effect that I think would be interesting because now runners understand a bit more about pain and this multifactorial. How does it affect? And I've used a little Bowie kind of clip here in respect to. Were you ever a Bowie fan? You David Bowie fan?
I'm only 26, so.
Of course, yeah.
I don't like the way you know.
17, and yeah.
No, true. You're way older than me, Matt. Let's be honest. Let's be honest with each other. Look at this.
Yeah. Well, you won't. I know exactly. Yeah, you won't recognise this kind of cha-cha changes will mean nothing to you, but it was a popular song from the 70s and 80s. Yeah.
No, it means nothing to me, mate. I'm an Ariana Grande fan. That's me. That's my age range. All right.
Ariana Grande, mate. All right then. So, treatments. Because I mean, one of the big things that I'm hoping runners get from this message is that when they, firstly, do they actually need to go and see someone, which is probably a whole other subject. But when they do go and pay the services of a professional, if it's not structural necessarily, or the percentage of structural involvement is less than they thought, what other things should they be considering or receiving when they do go and see a professional compared to what traditionally would happen?
Well, I think one of the problems with professionals, and am I a professional? I don't know, maybe not. I would say, I mean, this is a debatable question. I would say one of the problems sometimes with going to see people is that they often give you a call, like they will often say, oh, it's this or oh, it's that. And actually, people don't really understand. They don't really know. And the problem is sometimes suddenly they'll give you a kind of a description about what your problem is. And that description actually is negative. So, my desire is that I want to find out what's wrong with my knee. And someone tells me what's wrong with my knee, you know, whether they actually can know that or not, which I often would highly debate. But the problem is suddenly now you have a diagnosis or you have a structure to blame, and it doesn't always positively help us. So I think what we need to find is clinicians who are supportive, who are honest, and who involve the patient in the treatment process. A good clinician should listen to someone. A good clinician should work with them, and the way that they, they feel and they think. A good clinician should be able to provide a really good plan. A good clinician should put the patient in the driving seat. And one of the problems we have with clinicians a lot of the time is they do all the opposites. They scare people. They make them they'll offer them 20 treatments to their knee all passively and these different things. So really, what kind of treatment do people expect? I don't know exactly, but I do know a good clinician won't scare you and he'll put you in the driving seat of your recovery.
So talk more about, because some runners might not understand what you mean by passive treatments.
Yeah, so look, if you're going to go and get a massage or acupuncture or ultrasound for running related injuries, I would say the majority of the time I would not call that best practice. All right. So I think what we currently know best practice is about understanding a little bit more about you as a human, understanding some of the things that are affecting your training programs, your rest versus recovery, your training versus recovery, and all these type of things, So it's probably valid to have a look at the way that someone runs. It's probably valid to have a look at how much they run. It's valid to look at loading and exercise-based stuff. But I would say that too many treatments just based on making it feel better often don't make it feel better. And the other issue is that running-related injuries often don't hurt all the time. They just hurt when you run. So, why would you get a treatment that's based around reducing pain when you haven't got pain? Does that make sense?
It does, but answer your own question then. Why do runners go and get a treatment? What do they think is happening?
Well, okay. I think that sometimes we feel like we're again, it comes back to structure, doesn't it? That if our concept of pain is linked into structure, well, then someone's treating our structure. But unfortunately, these passive treatments don't affect structure. They have very little effect on structure. You cannot, with your hands or with a needle or with whatever, you can't really affect the structure of a knee or an ankle or any of these kind of things. If you did, could you imagine if you could actually affect the structure during a massage? You'd suddenly have all these bone spurs from massages, wouldn't you? You see what I mean? If you actually created these physical changes, what would that be positive? I don't know. It might not be positive. So I think we need to look a little bit more medium to long term with treatment rather than short term. And I think a lot of the treatments that you can get out there are focused on the short term. And I don't think that always relates well to running injuries per se, because running injuries don't happen in the short term, if that makes sense. They're running related, which I think puts them in a bit of a different bracket.
Cool. So I'm going to continue playing the devil's advocate. So this isn't me now. I haven't got my head on. I'm actually playing a runner because these are questions that I hear in clinic, and it's great to hear your perspective of how you deal with them. So, and I'm not, we offer dry needling here at Studio 57. Well, obviously we do massage. We do some therapies. We've got osteopaths who we've even had osteopaths in the past who will do kind of cranial therapy and all that sort of stuff. So, but ultimately, if a runner comes to you and say, well, look, I've had acupuncture on my Achilles and it felt much better afterwards, how are you going to explain that? You just said that you don't think these things help.
Well, so, I still think with every treatment, there is an element of a personal response. So we know that any treatment that someone gets, there is a wide range of responses that you can get to that. But I would also ask, you went and got acupuncture. So why are you back here again? If it sorted the problem out, then you wouldn't be in front of me. There must be something else going on as well here. So again, acupuncture, it has a short-term effect. So if you want a short-term effect, have acupuncture. But when we look at long-term or longer-term running injuries, such as an Achilles tendinopathy, I'm not really going to advocate some of these shorter-term treatment things. That's, it's all personal choice. That's my personal choice.
Yeah. And I'm still enjoying grilling you because that's
all right. Do it.
And also I feel safe because I'm not near you, because I know you're a bit handy with your left hook. I think you were famous for at one point. So I feel very safe here to challenge you. So what about, they're leading questions, but I want you to kind of like answer them for the audience because you'll probably put it better than I ever can. But what about someone has an Achilles issue? They go and have 6 weeks of acupuncture. I'm not specifically picking on acupuncture. I could say 6 weeks of cross friction therapy and people rubbing their Achilles tendon or ultrasound, and then they're better. How are you going to suggest to them or suggest to another client that they shouldn't go and pay for 6 sessions of that as well?
Well, I mean, absolutely. I think one of the issues here is that for every person you can find that it helped, you'll find someone that it didn't. But also, I think one of the key factors here is what else happened in that 6 weeks. You know, that's the problem that we have, don't we, with anecdotal stories. It's not controlled science. You know, it might be that you didn't run for 6 weeks, and during that 6 weeks you had acupuncture. Both may have, you know, it might be the not having run for 6 weeks was the beneficial thing. You know, so, but I would say with Achilles tendinopathy, that would be a very rare story. You generally find that people have had lots and lots of treatments, and actually the Achilles is not painful as much, but they still can't run.
Yeah.
And that's the key there. So it might be that it might get a little less sore, and they attribute that to having some needles poked in it. One of the problems is, and I'm going to give you some science here, if you look at something like acupuncture and tendinopathy, the whole idea of frictions, the whole idea was that you're stimulating a healing response. But that's not really involved in tendinopathy. That healing response isn't what's required to get the tendon better. Now, there are some biochemical processes, but it doesn't seem to be the traditional healing response that they've applied from some of these more invasive kind of treatments. I think, you know, you will always get people who have good treatments with things and it has a positive effect for them and that they continue to go back for that. But you will also find there are lots of these people that don't actually get better. They get an effect and they confuse an effect with getting better. Essentially, why have they got this long history of coming to see you? You know, this made me feel better. Why are you here then? Why are you not out running?
Yeah, and I think it's tricky because the runner, for example, I can hear the runners in my head answering you. I'm trying to put myself in their position. They'll go kind of like, yeah, exactly. It's coming back again. The medication's not working. But a lot of runners will say, well, so what? You know, if it works, it works. Who cares how it works? But that's one of my big things that.
But it doesn't work.
Yeah.
Problem is that what works is what needs to be defined. So it might make you feel better. It doesn't mean you're back running. There are 2 different things there. Yeah.
And if it worked, then we wouldn't see so many people who've already been for 6 weeks of acupuncture. Now they come to see us, kind of moving around the therapists.
And so if it didn't work, then why would we do it now? So you know, I think it's important that if you're going to see a therapist and they are not getting involved in your running and the things that seem to be run related, then they're not really treating you. They're just playing around with pain, which may or may not help your problem.
Yeah. I think, I mean, I don't even like the word therapist anymore. I mean, I went down the sports therapy route. I don't try not to call myself a therapist because I think even that's got connotations of lie down on the couch and I'm going to cure you and heal you. I can't think of a better word. And although we shouldn't really worry too much about what we call ourselves, it does because you're advertising yourself.
Yeah, I mean, I like to call myself the human shaman healer. I find that fits me the best, and I've got like a little tent out the back and we do these smoke things. And no, I understand. Our idea of therapy is often that someone does something to us. And you know, we exacerbate that by environment. We have a room with a little bed. You know, I don't personally, but we have these small little rooms that are confined to little beds, and they're mostly about doing things to people lying down. And from my perspective, that's not really therapy. You know, I think that the therapy encompasses a whole bunch of different things. Really, I suppose I would call myself a therapist / coach, because what I'm really doing, and this doesn't matter whether you're a runner, whether you have persistent pain or whatever, really I'm trying to coach you to be able to help yourself. So rather than me treating you, I'm giving you the tools to be able to go away and help yourself. And that's the difference between, I think, good therapists and bad therapists. I said it before, they put you in the driving seat.
Yeah, definitely. I think that's something that comes across on your courses as well, which obviously are aimed more towards therapists and personal trainers and physiotherapists, but it's teaching people how to become educators and coaches as opposed to therapists, kind of put more that hat on and trying to elicit ideas as well than just giving explanations.
Yeah, I think most therapists who come to my courses, they have learnt to be therapists. They've gone to therapist school, whether that's physio, osteo, chiro, sports therapy, whatever. So I can't help them be therapists. They've done that. They've passed the exams. They've been to university, whatever. But what I can hopefully offer people is a different way to apply some of those skills and to pick out maybe which of those skills are more important in different circumstances. So when it comes to running, when it comes to, chronic pain, these type of things, I don't believe people need someone doing things to them. I think they need people to help them do better to themselves, because it's not just about your body and your structure. It's about lifestyle, in a sports sense. It might be about recovery. It might be about nutrition. It might be about sleep. It might be about stress. It might be about timings. It might be about all these other factors. With chronic pain, it might be many of the similar things. It might be about stress. It might be about sleep, but they may be from different perspectives. But what everyone needs is more of a coach and a guide rather than a healer. The healer mentality makes people, unfortunately, move backwards and don't see themselves as a key factor. We are always the key factor in our recovery in our lives. Someone just sometimes needs to point you in the right direction, from my perspective.
Yeah, no, that's brilliant. I think that sums it up nicely. And it's a case of runners realizing that, the more time they have physiotherapy done to them, or they have a treatment, or they have anything done to them, in my view, it can play a big role, because it can help desensitize the system. I've always said that if you get somebody and they give you permission to put your hands on them, then it opens up their ears just as much as anything else. So that I joke about it. When you are giving a massage, I can't remember who it was, but somebody said that, most of the massage you do is with your mouth. I'll just give you a moment to
I'm not sure what you're doing, but I find it strangely attractive, and I want to.
Which is why we have little rooms with little beds and closed doors. But
and I mostly give massage hours, yes.
But a lot of the effect you can have when you're doing manual therapy is because you're opening up the ears to some education. And, if you just sat them down in a room and started telling these things,
I think clinical assessment, hands-on treatment, even exercise is always a window to interact with people and build alliance and build and find out more about people and communicate with people. Sometimes formal education and formal interviews of people don't work in the same way as an interview that's less guarded. And sometimes when we're working with people, that's the thing, isn't it? I think we need to view it as working with people rather than on people. But also patients and runners and whoever need to perceive that as well. They need to know from day dot you're working with them, not on them.
Yeah.
You said you can do that in a number of different ways. I would not argue that point, Matt. All right.
Yeah, and I suppose a useful take on of working with them is that they're going to have to do their homework as well. It's not just a case of come to clinic, have something done to them. You're going to set them up a plan, and that's one of the factors.
So I think the first thing is we have to have accountability and responsibility. If you want to be a healthy human being, well, no one can do that for you, unfortunately. And I think someone sometimes needs to give you a little clip around the ear roll and tell you that. In a nice way, or sometimes not in a nice way. I will sometimes have to brutally tell people, you are going to have to really be involved in this. This is the only way that it's going to work. And other times people are very motivated. Other times you may be able to motivate people with a carrot. Sometimes you have to motivate people with a stick, unfortunately. So I think sometimes it is about telling people, let's take someone with lower back pain who's obese and they have lots of comorbidities, they have very poor health. Well, at some point you are going to have to take responsibility for your health if you want to be in less pain. I can do that in a really, really nice way, but if I don't get the response that I need, it's my responsibility as your coach to tell you that maybe in a less nice way, unfortunately, because I would be remiss in my responsibility if I didn't.
Yeah. I think it's particularly with runners, there's still a problem because we read and hear about the elites very much having stuff done to them. There's stories of like Paul of Radcliffe, who's trainer, I can't remember his name now, but he said, I've never pummeled anyone like I pummeled Paula. Her pain was incredible. And it's what she needed. And it's tricky because when you're dealing with that population, the difference that carrying a little rabbit's foot can make, I suppose, in terms of context effect, can be huge. But that's because everything else they've got is 100%. But when it comes to a recreational runner, the little rabbit's foot isn't going to make much difference, or the belief that pummy is going to help. And there's other
go after the big rocks. So if anyone comes to you and quotes Paula Radcliffe, I would be inclined to say I see some differences. And I think it's really, really important to understand that Paula Radcliffe probably has a great training plan. She has a real lot of experience. Exactly. She's probably got her nutrition on point. You know, she's got people to help her with that stuff. So if she gets a massage, we don't know if that helps or not, because she's got all this other good stuff going on. And also, she's Paula Radcliffe, and that makes her not like you. One of the problems is that elite athletes are elite athletes. They are not the same as us. Otherwise, we would all be elite athletes, and we're not. So I think that using an elite athlete as an example of stuff is a poor example, because they don't reflect the normal runner or the normal footballer or the normal anybody. The fact that they are not normal makes them an elite. And being an elite means that they also get the big important stuff right. They get people to look after their training programs, look after their nutrition, look after all the things that probably go into being a successful runner. If you haven't looked after those things, don't worry about getting a massage, worry about the big rocks. And stop believing that you're an elite runner, because you're not.
I realised that a long time ago.
No, that's the point. That's the point, that we cannot use them as an example of the everyday person. These people are almost superhuman. They're the elite of the humans. You know, they are not a good example of human beings.
Yeah, that's true. It's very tricky though, because it's massive clickbait. It's like even the other day, there's a video on YouTube. I can't remember. I think it was Eliud Kipchoge or someone, but receiving this calf massage, he was in agony. He was gripping onto the end of this metal bed and screaming out. And it's presented as if this is what will make you an elite Kenyan runner, you know. And it's just the fact they're having it done and then they do what they do makes other runners think, geez, that's what I need then. I'm going to let this therapist beat the hell out of my calves and make me scream. It's very hard. There's a lot against.
I'd probably start with Kenyan thing. If you're not Kenyan, you're probably not the same as the Kenyans, because there's a reason why Kenyans seem to be good at this running thing. Right?
Yeah, but maybe it's because they get really excessive calf massages.
Yeah, I think it's probably more the Kenyan thing. But you see what I mean? It's like if someone conceptualizes, oh, you know, the elite Kenyan runners get it, so you know, it's like, well, no, it's because they're elite Kenyan runners, you know, and they're genetically designed to do things that you can't do, and they are genetically designed to run more miles than you. And this is just something that they get done. It doesn't make them a better runner, you know.
Yeah. There are some big differences. I mean, I remember reading an article about Kino Kip. I think I read circumcised with a stick, which was something which obviously doesn't make you.
Do you know what? My running has been quite poor recently. So this afternoon, I'm going to get circumcised with a stick too. And I think tomorrow, it's going to be a lot better.
Not tomorrow, because then they take you to a little hut somewhere and you have to run for a week to find your food in the outback somewhere. And yeah, I don't think this will happen.
They have to throw in some tricky stuff. Why can't they just, you know, do the stick thing and just say it's fine? Why do they have to do the, you know, I mean, tricky, these Kenyans, tricky stuff.
It's tricky though, because I mean, if as therapists now, if we're going to understand our runners and expect them to go and do their exercises or make the changes to their sleeping patterns or nutrition, we've got to be aware of what they're seeing and watching and hearing and listening to, and what's working kind of against us. And for us, it sounds ridiculous comparing ourselves to a Kenyan runner, but they'll just, you know, follow it, the same running routine, the same nutrition. I'm not saying they're going to circumcise themselves with a stick, but it wouldn't shock me if after this video one of them did.
Those runners are pretty crazy, Matt.
Oh, hold on, I've got a phone call. You don't watch yourself? Yeah, I've got 12 o'clock. Okay.
Yeah, I've tried to do it 3 times and it didn't make me a bit. I just thought if I took it right down to the nubbin, then I'd be a better. But it didn't work.
Anyway, let's move away from that area of the body. let's go
I was
on.
enjoying this. I have to talk so seriously all the time, you know, and we're getting into good territories.
Okay, let's put another thing up for you because I'd like to make some parallels. We've talked about runners who are injured or suffering from pain because that's an important distinction. The two aren't necessarily the same thing. What about runners who aren't? Oh, we kind of touched on it, but I'm going to put it up there anyway. By understanding pain, by understanding that it's an output and not an input, blah, 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 does that affect the way that runners potentially can reduce the risk of getting into problems and becoming injured?
Well, look, one thing about injury risk is just like pain. It's complicated, it's complex, it's multifactorial, and some of it is just plain random. So injury, we will never completely understand why people get injured. Now, as me and you were talking off air, I think, and apart from you telling me how tall and handsome and beautiful I was,
Did I say tall?
You said tall, definitely, Matt. But look, what you cannot, I'm 6'5", you can't tell from here, but don't laugh, Matt. I find that highly offensive. But, I think that, you know, injury risk is very, very contradictory, meaning that you'll read one thing and it will say, you know, this was associated, and you'll read. So a great example is how much your ankle flexes. It seems that too much and too little is related to Achilles tendinopathy. You know, it looks like we've seen an association between how much you run and an injury. And then another paper will say, oh, well, it's not associated. So there are so many things that, you know, what human beings want is they want this singular, don't they? They want this is the answer. Unfortunately, I think reducing injury risk means doing the good stuff. Having a good training program, cross-training, you know, making sure that you are, as a human being, in a good place to go out and run. I go for a run once a week and I bloody hate it. But it makes me better at boxing because I feel fitter. Whether that's a placebo, I have no idea. But I've noticed if I go out on a Saturday morning after having a drink the night before, my running feels horribly difficult. You know, so even things like how much alcohol I intake, you know, it might be a big deal. So it's if you want to tell people how to reduce injury risk, it's probably doing the good stuff. It's training well. It's smart training. It's treating your body well. You know, if you are burning the candle at both ends, socializing, working hard, running a lot, is that likely to increase the risk of your system developing a problem? I would have to say absolutely. So why do top-class sports people rest, eat well? You know, even a great example was the England football team even did some reducing of social media at the World Cup. They actually had a social media ban because your mind is just continually running when you're on social media. Now, I'm a fine one to talk because I'm a bit of a social media addict. It's a big part of, you know, what I do for work. But even that is working. It's you know, your system and your stress regulation is still working. And so if you want to reduce injury risk, be smart, do good stuff, be sensible about how much you run, vary the amount of running, vary the running shoes, vary the surfaces, vary the routes, treat your body well. Don't think that you're a superhuman. Don't think that you're Kenyan if you're not.
Exactly.
I just put that one in at the end.
Yeah. I suppose by putting reducing injury risk, I put that, I led you down that path. But if I put reducing pain risk in terms of reducing sensitivity, that sort of stuff, I suppose all the stuff you've just said is relative to that. If you're increasing, it's the same, isn't it?
Same shizzle. Injury and pain are intertwined, but you can have injury without pain and pain without injury. But the result is it hurts. That's what people are interested in. It hurts. If you would like to reduce how much it hurts, then or the likelihood of getting hurty, you know, a lot of our diagnoses that we give people are just hurty knee and hurty foot, and you know, they're not actually about structure and injury. Patellofemoral pain means your knee hurts. It doesn't actually give you an idea of particularly the structure, because the patellofemoral joint, quite a broad diagnosis, isn't it? It's just where two things come together. But if you want to reduce the likelihood of getting pain from your running, be smart. Do the things that people do that make you better at running. You know, but you could still do everything right and still get an injury. So this is the problem. You cannot eliminate injury. You cannot stop injury. You can reduce risk. That's the best that we can do.
Yeah. I think a lot of runners, there's an irony to, because runners have this, once you run a certain amount of miles a week, you become a runner, and that is your identity or self-identity. And when you become injured, well, once you start not being able to run, then you get more and more stressed, and therefore your pain sensitivity thresholds, I mean, you start hurting more, and it becomes a vicious cycle, doesn't it? And runners still think that the reason it's hurting is because they've done something to their ankle, when really they need to be kind of realize that they need to throw things out of their life which are causing them stress, because otherwise it's just not going away.
That might be. I mean, look. So I like the way that you touched on identity, and I think with exercise, my identity might be I'm a lifter, or my identity might be I'm a runner, or I'm a CrossFit, or I'm this, or I'm that. And actually, sometimes it makes it hard to control some of the variables. So if running is my stress relief, or running is my social life, that makes it harder for me to control the variables, because I use running to beat stress. I'm stressed, so I go out and I run, and that in itself, that relationship could be problematic. So I think it's good to have an identity, but sometimes the identity can be more detrimental than it is positive.
Oh, definitely. Especially with social media, because the amount of runners who they change their identity from, oh, I'm doing part one, I'm getting my PBs, to I'm the injured runner. And suddenly all over social media, they're the injured runner. I think that can be just as destructive as anything if they start giving themselves that label.
Well, we see that in all pain scenarios, don't we? Where people are associated with being in pain. And we might see that from patients with long-term persisting pain, patients who join certain groups that are about being injured or painful. Again, can it become an identity? I'm not suggesting that is negative or positive. That's not the suggestion here. So for some people, it might be dramatically positive. For other people, it might also be negative. But certainly the idea of identity, how that affects our behaviour, is very real.
Yeah, and I think, I mean, it's one of the probably the many problems about social media, I think, that we're dealing with now. Just not being able to list all your runs on Strava and just feeling that you're not yourself anymore. It's something I definitely see in clinic, and explains why a lot of runners aren't getting better as quickly as they should be.
People aren't running for themselves anymore, are they? They may be running for outside appearance. So if I'm this guy who does these amazing Strava runs and posts them up, and that's what I'm known for, well, that's going to be problematic for limiting the amount that I run, because no one is bulletproof and we just run forever. And this is one of the problems I find with things like biomechanical analysis, is it suggests if you run perfectly, you'll never get injured. And that's just not true. You know, it's actually that there's other factors involved there, such as running volume, the amount of stress systemically I'm under, previous injury history, all these different things. So that's sometimes, I think, the view that people have. If they fix this thing about their running, they'll be superhuman. And unfortunately, no one is superhuman apart from the Kenyans. And you're not a Kenyan, so give it up.
I've lived there for a while, but I suppose I'm not. Yeah,
I'm not buying it, Matt. You're not selling your Kenyans to me, buddy. I know that you may have an identity of being a Kenyan, but yeah, you're not there, bud. I'm sorry to be. It's another one of your multiple personalities, obviously.
Fair enough. Okay, so God, look, 54 minutes already. So take-home points then, rounding it up. I mean, what I've kind of gathered from you so far is understanding that pain doesn't equals tissue damage necessarily.
Yeah, absolutely. That pain doesn't automatically mean that you have a damage or a really definable injury. In fact, many running injuries can be really, really difficult to define. You know, also, they'll come in and point to the knee, and then it will jump around and it will move around, and it will hurt at different times and in different intensities. And people want a really, really singular answer. And sometimes that's very, very difficult, because pain doesn't always work that way.
So, and then the knock-on effect of that is when we see a professional to sort out our pain, we automatically assume that we need something done to our knee or done to our ankle. Yeah. And that may well not be the case. So that's kind of take-home point number 2, is don't expect someone to necessarily be able to cure your pain by doing stuff to you. the fact that when it comes to understanding pain, we know that we can fear pain and that can cause problems, or we can choose to ignore it, the other end of the spectrum, that can cause problems. And then when it comes to reducing the risk of suffering pain, then all the other external factors you mentioned, like stress levels in life, recovery, sleep, all those sort of things can make a big difference as well. Fantastic. Okay. Well, I think you've mentioned quite a few things there, which hopefully runners will be able to take on board due to the wonderfully simplistic way you put it.
Many years of working with runners, sometimes people don't take on board what I have to say because they want to go running. So that can be difficult.
What you don't obviously your courses are aimed at therapists and coaches and physical or anybody who works with people in pain, basically, isn't it? What have you got lined up? What have you got coming up?
In the new year, I'm off to Taiwan on the 2nd of January. Going to go to Taiwan for a little bit, and then I come back. I'm in San Diego and Portland early February. Then I go up to, I'm in Australia in March. So I think this year I visited maybe 12, 15 countries. And I think I'll probably do the same next year again. I'm booked all sorts of places up to about 2020 at the moment. So, and I'm not really sure why. I mean, as you can tell from the last hour, I've got a whole load of waffle, haven't I? I mean, look, maybe it's my champion waffling skills. You know, I don't know.
Oh, just the sexual kind of. Probably
just radiating from it. It's probably my, intense muscular frame coupled with my model-like good looks and 6'5" height. Yeah, am I selling it to you?
This is the problem of people listening to the podcast. They're not getting the visual impact of Mr. Ben Cormack on screen, but
try and run me down.
That's their choice.
You know it's all true. Just face it. Just face up. You're just jealous. That's the problem here.
But you're still managing to fit in courses in London and in the UK as well, aren't you? People don't want to travel that far.
Less and less, to be honest with you. Like this year coming up, I've only got two UK courses. I don't know. I think that. I just people ask me to go places and I go different places. So it's just become unfortunately, and London's so expensive. To get called to venues and for people to go there and stay. And so the UK's, can be quite a tough market actually sometimes for courses. I think just just things like travel and accommodation and things like that. London is just like, and I'm a Londoner, and it's just ridiculously expensive. Yeah,
it makes it tricky for me, mate, because I mean, I get therapists asking me, well, what should I do then? I've listened to RunChatLive and stuff, and I understand now that I shouldn't be looking for the latest manual therapy technique. I want courses that teach me how to become a better coach or educator, to understand pain. And normally you're my go-to guy, but if you're doing less than...
Well, I mean, I'm in London in May. I mean, I've got a course in London in May, so I'm still here, buddy. I'm still here for you. I'm still your go-to. I'm still your go-to. Even though you think you're Kenyan and you're not. I still love you.
And you still offer online support, don't you? You still got like your mentorship stuff and that going?
Yeah, so I do more online stuff now. I find it helps me. I just recently started an online program, and I think we had therapists from like 20 different countries join up all over the world, which was really, really fantastic, and just shows that people still, want some education maybe that's driven in some different directions rather than that kind of healer mentality. It's very much about working with people and putting people in the driving seat and that kind of stuff.
Yeah, I think that's the thing. Although I miss, and I think it's tricky. I think we're in danger of losing that face-to-face contact when it comes to courses now, because online makes it so much easier. But I think that said, if for therapists wanting to evolve and become better therapists, there's so much information out there which they're not taking advantage of online, which is probably free. There's your website, Core-Kinetic.
COR hyphen. I only recently found out it was a hyphen. KRNETIC.com. So Cor-Kinetic. Cormack movement. Do you like it? Cormack movement. Cor-Kinetic. Do you get it? Do you see it?
Yeah, no, I get it. I understood when exactly. But yeah, there's so much information on there, so you haven't necessarily got to pay thousands of pounds therapists. Just start following the people that I follow and looking
so much. Almost, I suppose, what I charge people for. Obviously, I've got to make a living, and I feel like what I give is fairly ethical. but I would like to see myself as a bit of a filter. So there is all this information out there, but sometimes people need it to be filtered a little bit, you know. So I see myself as a bit of a filter. I'm not the world's best clinician. I'm not the world's best researcher, but I am reasonably dedicated to filtering what I think is good information people need to know.
Yeah, no, I'd agree. I think that's a good definition of you. You are a filter, a conduit.
But a really cool, handsome one.
Or just a con. We can short.
I don't know. You'll have to ask someone else. But this is turning into like Watchdog. You're exposing me on air, aren't you? What anyway. Was it Anne Diamond? It was, yeah. Now you're showing your age. Yeah, so much for 26. Wow, sorry, buddy. It slipped out, didn't it? I know.
Okay, so so runners, no, Ben's posts are going to go way over your head. It's for therapists. Don't start going down those rabbit holes. You'll never run again. But runners, hopefully you have got some information which is valuable to you. For the runners listening to this and watching this, it's more about understanding what to expect when you do go and see another therapist.
Which is
if they are putting you down and doing stuff to you, then you're missing out. There needs to be education involved. There probably needs to be you doing some movement. I think Diane Jacobs put it nicely. It's kind of like a burger where you've got the education, maybe some therapy because she's into her neuromodulation, but definitely then some movement, some active movement on the end. It needs to be a combination of those three factors. If there's only manual therapy done on you, you're missing out on the education. If they make you do stuff and you don't understand why you're doing it, you're missing out on the education, on the actual active movement. So yeah, hopefully runners have got something useful to take away from that. Ben, thank you very much. I know you're a busy man. Once again, people, if you've enjoyed what Ben has said, then please do share. I'll put a link to Ben's website in the comments underneath. So if you're a therapist, well, if you're not following Ben and you're a therapist, then you're not really a therapist in my view.
Oh, come on. Yeah. I'm not quite. It's a very beautiful thing to say, but I'm not.
No, who are they fooling? You know, who are they fooling? They're definitely not up to date and evidence based. So there we go. Look, mate, thank you very much again for your time. I really appreciate it.
Always.
I'm going to sign you out of here and then I'll say goodbye to everyone. And then maybe I'll come back afterwards and we'll just talk the two of us.
All right, buddy. See you later. Bye-bye.
All right. Thanks. Okay, people. Well, that was great. That was very entertaining, as always. Episode 14 with Mr. Ben Cormack. Like I say, yeah, therapists, you need to be following Ben, full stop. Definitely. Just to start challenging what you've been told on courses, what you've been brought up to believe, etc., and to start opening your mind up to some critical thinking. The great thing about Ben is you'll notice with me, he answers questions with another question, because that's what an educator does. You know, you don't just give people answers, you encourage them to think, to self-analyze, and then come up with their own answers. So wonderful. I do hope the runners who've listened as well have got some better understanding of pain and how that affects your current way of dealing with pain, avoiding pain, etc. And that's the last episode of RunChat Live for this year as well. So we've gone out on a high with Mr. Cormack. We'll be back there in January. We've got some exciting guests lined up. And to keep in contact with that, just follow us on social media. Like I say, we're a podcast now. I'm slowly uploading old episodes. So you can find us on Spotify, iTunes, etc. As always, I just please like and share and all that. We don't make any money out of this. Ben certainly doesn't make any money out of this. I don't. It's just a case of sharing the good word. So if you've enjoyed it, share it somewhere, like it if you've got a like button, etc. But that's it for today. That has been a runner's guide to pain. And so all I need to say is adios, thank you, and goodbye.